The transmissions of the Mycobacteria tuberculosis is through the inhalations of the respiratory droplet. So when the pathogens go all the way to alveoli, it will capture by the alveoli macrophage. And normally, when the macrophage phagocytose the pathogens, it will form the phagosome, and the phagosome intracellularly will fuse with the lysosome, and the enzyme inside the lysosome, it will lyse the pathogens inside the phagosome. But in Mycobacteria tuberculosis, it has something that's called mycolic acid. So mycolic acid is something that is in the cell wall of the mycobacterium. So it can produce two virulence factor. One is called sulfatide and the other one is called court factor. So sulfatide, it can inhibit the phagosome lysosome fusion. So if no fusion of the phagosome and the lysosome, the enzyme inside the lysosome cannot lyse the pathogen inside the endosome. So that's how the mycobacterium can survive inside the endosome. So it can keep proliferate inside the phagosome, and it can keep proliferate until where the endosome cannot contain anymore, and eventually it can lyse the macrophage, and can release of the mycobacterium extracellularly. And the second virulence factor is the court factor, and it can induce the release of the TNF alpha. So TNF alpha is a cytokine that produced by macrophage. One of the function is to recruit more macrophage. So together with the release of the mycobacterium extracellularly after proliferation, and with the recruit more macrophage, so they can actually work together. So newly released Mycobacterium tuberculosis, it will capture by the newly recruit macrophage, and this will keep happen, or you will be the cycle will be repeat for the first 3 weeks of the infection. So after 3 weeks of the infection here, some mycobacteria will migrate to hilar lymph node, and in the hilar lymph node, the macrophage, or we know as the antigen presenting cell, it will present the pathogens to naive T cell by the MSC2. I have a little note here. So we know that usually the intracellular pathogens, it will be presented with MSC1, but not in the case of MSC mycobacterium. It will presented by the MSC2 because mycobacteria is actually contained inside the phagosome, so it's not in the phagosome, it's not in the cytosol. That's why it's not presented by the MSC1. And after presenting the pathogens to the naive T cell, the APC, it will secrete the IL-12. So this IL-12, it will induce the differentiation of the naive T cell into the Th1, and Th1, it will secrete interferon gamma, and interferon gamma here, it will causing activations of the macrophage. So activations of the macrophage can cause fully form of the acidified phagolysosome, and they are capable of destroying the intracellular mycobacterium. And also they can differentiate the macrophage into the epithelial histiocyte and multinucleated giant cell. Together they form the granuloma. And granuloma specifically in the mycobacterium is called gone focus. And if you can find the granuloma in the hilar lymph node, together they with the gone focus is called gone complex. And the activations of the macrophage is also cause the release of the cytokine lysosomal enzyme generate the reactive oxygen species and activate of the complement. Together, all of this, it can destroy the Mycobacterium tuberculosis and it generate the caseating granuloma. So after the primary infections, several outcomes can happen. So either it can heal with the fibrosis calcification and become latent. So these are the most cases, right? And secondly, it can progress systematically and become spreading systematically, but become bacteremia, and this is called the miliary tuberculosis. So you can find a mycobacterium in any organ, and this can quickly progress to death. So this is very lethal. Number three, it can cause reactivations of a latent infection. So usually this one is seen in the immunocompromised patient, especially the patient that failed to mount the CMI response, example in the HIV, and down regulations of the TNF alpha can also cause reactivation. So as we know that TNF alpha, the function is to maintain the granuloma. So infection will be contained inside the granuloma. So when we don't have the TNF alpha, that means the bacteria inside the granuloma, it will spread out. So it will cause reactivations. That's why patients that undergo the TNF alpha inhibitor therapy, they are at risk of reactivations of the latent tuberculosis. So we need to screen them first before we initiate the TNF alpha inhibitor. And usually the reactivations of the latent therapy, it affects the upper lobe of the lung, and the classic symptom that we usually find is the cough, the hemoptysis, and night sweat. And in the reactivation, it can affect other part of the body. So it not just affects the lung, and it can affect, for example, the spinal column that can cause the heart disease, and it can cause meningitis and tuberculoma.